and you guys can unmute and ask questions if you want. It's a smaller group, not being the entire class, so that's fine with me. Or if you'd rather type your questions, you can do that. So let's start out, guys. First thing we're going to start out with is asking if you guys have any questions about any of the material on the study guide, and we'll start with fundamentals first. So is there anything that you're like, I'm not sure what I need to look at or anything like that on the study guide?
Hi, Professor Trainer.
Hi, Shelby.
So for chapter 16, interpreting and validating assessment data, are you like specifically talking about like subjective versus objective, or are you wanting to go more into like assessing a patient type data?
So, it's basically you've done your assessment. Now, what is the difference? So what I'm kind of more looking at is what is the difference between interpretation versus validation?
Okay.
So you've done your assessment, and what does interpreting the data mean? Like, what is the difference between the two? So, what do you think, Shelby?
Like, what do you use to interpret? Like, so you're like what you use. So like your sources, like to look at what you found and determine. Is that what you're talking? I'm just confused.
No, that's okay. That's okay.
So like,
this is good.
States and then what it ends up being in the end. Sorry, this is Courtney.
Hi, Courtney. So yeah, kind of. So interpreting is like, okay, you have this data. Now what's your interpretation? For instance, the patient's short of breath, they have diminished lung sound and crackles. So you might interpret that they have a respiratory issue, maybe COPD or pneumonia. But how are you going to validate that information? So then you're going to go to the chart and you might look at the chest x-ray report, and the chest x-ray report says the patient has atelectasis and that the findings are consistent with pneumonia. So you interpreted what you found, and then you went to another source to validate that finding.
Okay. So like sources of data, like patient, family, and significant others, healthcare team, medical, scientific literature, nurses' experiences. Is that kind of what?
That would be sources of, and I'm really drilling down to the difference between, because there is confusion between how you interpretation. So interpretation meaning you've got all the data from all those sources. Now, what does it mean to you as the nurse? And then, okay, so now you've got this data. Now, how do you validate that it's accurate data? Right, Mercedes. So yeah, validating is double checking and verifying that your interpretation is correct. So you might have a patient and you've taken their temp and their fever, they have a fever of 101.9, they're diaphoretic, and you're like, wow, I really think they have an infection. And then you go and look at their labs. So you validate that by looking at the labs and seeing that they do have an elevated white blood cell count.
Okay.
So validating is a lot like fact checking. You've got your facts, you've interpreted what those facts mean to you and your patient, and now you're going to fact check it and make sure that it is accurate. Thank you for that, Shelby. That is a tough one that students have struggled with in the past. So I appreciate that question. Anyone else have anything else on the study guide? And like I said, feel free to unmute yourself.
I have one for chapter 27, the National Patient Safety Goals.
Mm-hmm.
Those are the ones that you sent out and what you called? The announcements, correct?
Yes.
Okay, so we need to review those as well.
Yes. The
Okay.
ones that are really old. Well, they're not really old. They're still relevant today, but yeah, they are kind of I was like, wow, 2018, how lovely.
Professor, I did have a question about, oh, I'm so sorry, Natalie. Go ahead. For the surgical asepsis, are you wanting like the process of it or what it is, or are you just wanting us to know everything because you can ask us whatever?
Well, I do want you to know everything, of course, but so a lot of people, what I really want to drill down to on that, Courtney, is surgical asepsis. When I say surgical asepsis, what kind of technique are you using?
So for surgical asepsis, meaning like autoclaving instruments or scrubbing in?
Yes, and that is, what technique is that when you do all those things?
Sterilization?
Yes!
Okay.
Sorry, get really excited. Yes. So surgical asepsis and sterile technique are the same thing. Okay?
Cool.
Yes. So then the difference then, because there's a lot of confusion with surgical asepsis versus medical asepsis, which is being clean, not sterile. So yes, that's exactly what I was looking for.
Okay. Awesome. Thank you.
You're welcome. Okay, Natalie, what else? So I'll get to you in just a sec, Veronica. Veronica.
The restraints portion of it, are we looking for the orders and like the documentation for that, or and then as well as the positioning and
So with the restraints, specifically, there's a couple of questions about restraints. One thing I want you to be aware of is the use of alternative to restraints, what things you might do as an alternative. Also, how would you assess that the use of restraints has been successful, and that your alternatives have been successful? Things like you have a patient who's constantly picking at all their tubing and you don't want to restrain them, so you give the patient a huge pile of washcloths and you tell the patient, can you fold these, please? Laundry people just didn't do a good job, and they spend the whole time folding them. Oh, thank you. You take them out, you bring them back in again, and have her just refold them all over. So that's what I'm more looking at. I want the reason why is because there's such a focus on not using restraints. I want to make sure you guys are aware of alternatives and can think of alternatives. And how are you going to know when the alternatives work?
Okay. Thank you.
You're welcome. Okay. Yes, Mercedes, mitts are considered restraints. Chapter 29. So, Veronica, chain of infection, you need to know the chain of infection, like what are the different parts of the chain? What mode of transmission, host, that kind of stuff. Surgical asepsis we just talked about. Standard precautions, you guys need to know your standard precautions. There was that whole slide with just the breakdown. Actually, let me make sure I get you the page. I've got the book. That's why I pulled up my book. Okay. Of course, I go to the back of the chapter. Not helpful. So, chain of infection, you need to know your infectious agent, reservoir, portal, mode of transmission, portal of exit, portal of entry, and the host. And I want you guys to have an idea of what you can do at each step that might stop it. In that step, surgical asepsis, we talked about being, I do say a lot. sterile technique. Then the standard precautions. I know I took the table from your chapter, so I'm trying to find it, guys. Could have sworn I took it from here. Apparently, I did not. So, know your standard precautions. Assessing risk of infections in adults. I know that one is a specific. Okay, so the assessing risks of infection in, thank you, older adults is on table 29.3 on page 450. So that's where you're going to look at that. You're going to look at, chronic disease, some of the causes, and what happens. So kind of basically know the risk factor and potential outcomes. I want to say also, it's not must not be on this test if it's on the midterm then, because I'm like, there's another one. Disinfection and sterilization. So that's on page 456. Okay. So things we're looking at, first one is like the categories. So your critical items. We're talking about surgical instruments, cardiac or intravascular catheters, urinary catheters, implants. All of those have to be sterile. And then semi-critical items, so items that come in contact with mucous membranes or non-intact skin, respiratory and anesthesia equipment, endoscopes, endotracheal tubes, GI endoscopes, and then diaphragm fitting rings. I'm more interested in the scopes, like the endoscopes and the GI endoscopes. And then, of course, non-critical, your bedpans, your blood pressure cuffs. They don't have to be sterilized, but they have to be clean. And then different examples of the disinfection process and sterilization. So moist heat, it's steam, chemical sterilants, ethylene oxide gas, and then, of course, just boiling water. See if I can get into it now. Oh, I think my computer is thinking. You guys are so awesome about sharing things with each other. It's just every group gets better and better and better when it comes to yes, Veronica, it's all multiple choice. Yay! At least for the fundamentals, it is. Sorry, Natalie, your whiteboard's just taking some time to come up. So, okay, so that was chapter 29 Veronica had questions on.
I did have a question, Professor Trainer. It's Courtney again. Acceptable range of heart rate. Did you want us to know all over, like adults, adolescents, infants, or?
So ideally, it would be wonderful for you to know all of them off the top of your head. So the acceptable ranges, Courtney, they're on page 499. And it's table 30-3. I would focus on the adult and the infant.
Okay, thank you so much.
You're welcome. Ooh, my ceiling fan is making noises. Mercedes, it is table 30-3 on page 499. You're welcome. Okay.
It's Natalie. Can the code of ethics?
Yes.
um,
Told you guys I was a Slytherin.
so the code of is there? I can't remember. Is there a list somewhere that we can go look at, or?
Not really.
Okay.
But so what I'm gearing towards, so when I give you guys like that, I like even specifically told you what page it's on.
Is it more like the definition?
Exactly, Shelby. So when I do that, I try to drill down to a specific section in that chapter. So for instance, code of ethics actually means on page 3, where it says code of ethics, like that particular, and more looking at the definition. So that's basically what I'm drilling down to when I say the code of ethics. When I'm talking about, say, we said roles of a nurse. I know what's in here. So you've got your professional responsibilities and roles. I know that's a lot, but basically no caregiver. You help patient maintain and regain health, manage disease. So basically just the very basic definition and the different roles. The Nurse Practice Act, know where you would find your Nurse Practice Act and what it is. So the Nurse Practice Act, guys, comes from the state board. Okay. And then nursing novice to expert. So that's Benner's theory. So that is actually literally page 2, box 1-1. So novice is you guys or a new grad nurse. Advanced beginner, you have some experience, less than maybe about a year or so. A competent nurse, you've had same clinical position. Now this is the key, guys. The same clinical position. So just because you're a nurse doesn't mean that you're a competent nurse in all clinical areas, because there are specialties, right? So if you are, say, competent at chemotherapy and then you get moved to an orthopedics unit, you're going to go back down to basically novice all over again. Yep, that's pretty much it, Shelby. So that's the really important part with the Benner's theory, is knowing that even though you're a nurse, it doesn't mean you're an expert in all areas. So you may, if you change, go to a different area. So I have been a nurse for 17 years. Yeah, 17 years this month. And I've been in different areas. So when I first graduated from nursing school, I went into like progressive care, telemetry, step down. And I worked in that area for, let's see, 2003. And then I moved 2009, 10. So probably, no, 2008 is only 5 years. So by that time, I mean, I'm a proficient to an expert in that area. And then I changed into a totally different job. And yes, exactly, Shelby. So you're an expert. So you have to have like at least 3 or more years of experience who in a certain clinical position. And you kind of, at that point, you developed what's called an intuitive grasp. You just intuitively know. So in the grand scheme of nursing, I'm an expert in actual like nursing process, but in different areas, I'm different. So I did home health. I started out as a novice again. Did I feel like a novice? No, because the basics of nursing principles are always the same, but the specialty is very different. So, for instance, if I went to labor and delivery right now, I would be way out of my element. I don't do moms and babies. I never have. That was my mom's expertise. She did, mom baby. She went all the way up to become a nursing director of a mom baby unit, but I don't know a whole lot. Put me in there and I'm crazy. Now, that's not to say that I can't learn things. So when I was in ICU, I was actually working ICU progressive care in North Las Vegas, and I was on night shift, and they needed someone to monitor a patient in labor. She was actually in labor delivery, and she was on a magnesium drip. The thing is, a patient on a magnesium drip like that, they were trying to stop premature labor. It requires extremely close monitoring, and basically you have to have a 1-to-1. So one nurse for that one patient. And everyone else was like, oh my God, no, I don't want to go. And I'm like, I'll go, fine, no big deal. Because I figured the other nurses who worked there, who were there in labor and delivery with me, if something went in that direction beyond where I felt comfortable, they'd be there. Another time, same job. I was working progressive care, and they asked if I would float to the postpartum unit. So after they've given birth, it's just moms and the babies. And I'm like, sure, whatever. It's a medical surgical patient with a fundus. Okay, I remember fundus. I know how to check fundus, and you guys will learn those. And I got over there, and the charge nurse, super, super awesome. First of all, she gave me kind of a rundown of the unit. I took a report on the moms. She said, you'll take the moms, you'll have you do that, and then I'm going to do the babies. I'm like, cool, because I don't know nothing about birthing no babies. But so that really, yes, it was out of my element, but it wasn't outside nursing. So it's kind of weird. But to actually become proficient, you'd have to switch. So sorry, totally off topic. Systemic effects of immobility. So we covered the other stuff. Let's go to chapter 28. Unless anyone has anything else. Because I'll just keep moving along.
I do have a question, Professor, but it's in chapter 30. Do you want me to just wait?
No, go ahead.
So for the blood pressure auscultation, I was just curious because I'm in the fundamental study guide, and I'm just wondering if you're more so wanting the process of taking a manual blood pressure, or if you're wanting like the difference between like what is systolic pressure, what is diastolic pressure.
That part you won't have to do until we get into oxygenation. What I'm more looking for is so page 507.
Okay.
And I want you to look at figure 30-14. That's the Korotkov phases.
Okay.
Mm-hmm.
That was my next question.
Yes, because
Okay.
You get a lot of people do that. I mean, a lot of people make the same mistake. You don't get it up high enough to, and you don't get an accurate reading. So that's what I'm looking at. And then also, Courtney, if you see on page like 506, it starts that section that says auscultation.
Okay.
So kind of that section on auscultation around to the assessment in children, but definitely that figure 30-14.
Awesome. Thank you.
You're welcome. Anyone have anything else, right?
So for the vitals, like the temperature and stuff like that, are you gonna want to know in Celsius or Fahrenheit?
You know what? I don't think you need to know that.
Ah, yes. Okay.
For this class, Natalie.
Well, yeah.
So yeah, so basically body temperature. So I'm looking at that would be page 488. And that's where that body temperature, it starts with the physiology. So that's kind of where we're looking at. Heat loss. So things you might think about are things that you can do to help decrease heat loss. I know that's in there. Especially maybe like, oh, I don't know, infants. When we're looking at the factors, since we're already in that chapter, I'm just going to keep going with that particular chapter, guys, and then we'll go back to 28. Factors affecting body temperature. I'm specifically looking at the section about age, and that's on page 489. And that might be, oh, I don't know, particular to say, oh, infants again. Maybe. Wink, wink, nudge, nudge. Blood pressure we talked about. Okay, factors influencing pulse rate. Whoops, too far. Okay, factors that influence pulse rate is also page 499, and it's table 30-4. So things you're thinking about are exercise, temperature, medications might be really important there. You know, like, I don't know, amlodipine, which is a calcium channel blocker. Or, you know, digitalis, which is digoxin.
Can you repeat the page number one more time?
Yep, 499.
Thank you.
You're welcome. So yeah, wink, wink, nudge, nudge. That medications one might be the important one, although you should be aware of all of them. Let's see. Okay, so pulse, and we talked about acceptable heart rate. Okay, now we'll go to, you guys didn't like chapter 28. We've like totally gone everywhere but that. Just kidding. Okay. Immobility, systemic effects of immobility. I know there's a figure for this. Actually, no, there's not. So page 410 talks about, and that's where you see systemic effects. So unfortunately, I wasn't able to drill down to one of those specific sections. And the reason why is there's probably more than one question. And I say, you're probably going, don't you know? But, you know, there's probably more than one question. So you're going to look at metabolic changes. What kind of things are you going to see? Respiratory changes. What kind of things, like what complications are you going to see due to immobility, like atelectasis and pneumonia? Any cardiovascular changes, so orthostatic hypotension, musculoskeletal changes, you're going to have muscle wasting, skeletal effects, you're going to have disuse, osteoporosis, contractures, urinary changes, so you can end up with urinary retention and renal calculi or kidney stones. And then integumentary, so most of you probably know that, of course, you're not mobile, your skin, the pressure cuts off vascular, and then that causes these, sores. So that's definitely something that you want to consider. So basically in each section, rather than knowing specific like metabolic changes, I want you to know, like, what are we looking at? So negative nitrogen balance with metabolic, respiratory, the complication could be atelectasis or pneumonia, cardiovascular, orthostatic hypotension, blood clots, musculoskeletal, like we talked about, and then urinary elimination. So Any questions on that specifically?
No, I think I'm good on the systemic effects.
All right. So now we got to talk about psychosocial, though. So psychosocial effects. Of course, if you kind of look at the way we are now, people are going nuts with not being able to move about, not in a physical sense, but you're not really being able to leave your home. Yes, Mercedes, like what disease processes in each of those different categories can occur? Oh, there it is. Psychosocial effects. I found it. Thank you, Shelby. So some of the alterations that can happen, like sensory, coping, loneliness, depression, it's a small little section, and I literally just mean that little section that says psychosocial effects. Things, social isolation, loneliness. Sorry, guys, I don't have a lot of light in here because it gets too hot. Depression, worry about disability, withdrawal. So those are the things that you're definitely looking for. Body alignment. Oh, yeah, I remember this. I want to know. Oh, so there's a section on body alignment. It's on page 417. Very down at the bottom on the left-hand side, and then it goes over to the right. So things that you're looking for, I'm thinking more of actual positioning, so standing and sitting. So like sitting, characteristics that you're going to see in someone, head erect, neck and vertebral column in straight alignment, weight is distributed evenly, thighs are parallel and horizontal, both feet supported on the floor so the ankles are flexed. Of course, with someone who's short, use a footstool, so that would be me. And that doesn't happen. And then you want to make sure there's a 1 to 2 inch gap between the edge of the seat and their knees. You don't want their knees to actually be hitting the edge of the seat because it actually cuts off blood flow. Because remember, we have a popliteal artery. So if you are sitting directly back and it's putting pressure on that artery, you're decreasing blood flow in your legs. Forearms supported on armrest or in the lap. So again, sitting, you're erect, in good alignment, feet flat on the floor, ankles are flexed, and you're not sitting directly. Now, those of us with short legs, if you want to sit back in the chair like me right now, in my chair, the backs of my knees are hitting my chair. Because in order for me to sit back and be able to use the backrest and the armrests, I have to sit far back. And that, because of the way the seat is, it touches. So I try and keep my feet up and whatnot. And then also, look at standing posture, head erect in midline, and those kinds of things. I think I even talked about that in lecture. Okay, psychosocial. So now we're talking about psychologic hazards of immobility. I want to say that's the same page as the effects, but I don't. Metabolic, respiratory, cardiac. Oh, maybe not. Yeah, psychosocial effects. So it's actually the section that says psychosocial changes, guys. And it's on page 427. So depression, mood swings, anticipate changes, provide them with meaningful stimuli. So plan nursing activities so patient is able to talk and interact with staff. So I like this one because these are the interventions. What are you going to do to help prevent the patient from developing that irritability and depression? What kinds of interventions will you do to keep them in this world? So yeah, page 427, the very bottom on the right hand side, it starts psychosocial changes, and then it goes over to page 428. Specifically interventions. And then I think this last, yeah. So the last for fundamentals anyway is in chapter 28 is positions. So this one I had to keep really broad because there are several questions about the different body positions. So what I want you to look at is, so you've got supported Fowlers. So head of bed is 45 to 60 degrees, knees slightly elevated, is a supported Fowler's position. Supine on spine. Yes.
Sorry.
No,
Will
you're
you be
fine.
asking us about like semi-Fowlers, high Fowlers, the different Fowlers, or just supported Fowlers?
I think there may be a question on semi-Fowlers. I know there's not one on high Fowlers.
Okay, semi-Fowlers. Okay, thank you.
You're welcome. And then I know there's one on Sim's position. Pretty sure. Sim's position. But to know, and one thing I really wanted to get out of this too is supine is on spine, prone is when you're on your front, on your chest. So supine on spine, and then prone is front. My mom's the one who taught me supine on spine. It is on page, well, let's see, where I want you guys to start is on page 429, but it truly actually starts positioning techniques on 428.
Are you wanting like the considerations or the methods or troubled areas or all of it?
That sounds great. No, I'm just kidding.
Yeah, okay.
No, so I kind of want you to know what it is. So if the test says, oh, a patient is in Sim's position, you'll be able to go, okay, well, that means they're in this position. They're on their side. It's kind of this. But then also want you to know trouble points. Oh my gosh, Natalie, look at you.
Actually, that one that one was actually done by Adriana. Her and I are splitting up the outlines for every chapter.
I'm telling you guys, every class gets like even more impressive than the last sometimes, I swear. I mean, all the terms have been great. But just, it was like there was some good working together in the cohort 3, and then the next one got even better, and now you guys are like even as like wow, it's amazing. I'm glad you guys are working together so well. Okay, so that went over positions. Any other questions on fundamentals?
For sorry, one last question, I promise.
Fine.
For
Courtney,
chapter,
don't apologize.
it's a habit. I'm sorry.
You're fine.
For assessing the risk of infection in adults, are you just wanting to know like signs of infection to look out for, like in the like when you would be doing your assessment of the patient?
I missed that one, didn't I? Thank you for bringing that up because I missed that. We didn't do that one. Or maybe we did and I just forgot already. Let me Assessments. Okay. I have to go back to the beginning. Come on, Shelby, where are you with my page numbers? Just kidding.
It's page 450.
Told
But
ya.
I think what you mean is the table 29-3.
You are right, yes. So page 450, table 29-3. So the risk factors, chronic disease, maybe specifically, and things that might happen with the chronic diseases, nutrition, lifestyle, maybe. I can't remember. Oh, look at that. Travel history. West Nile, SARS, which COVID-19 is a SARS virus, by the way. Yay. Hantavirus, that's always a lovely one. Yeah, so I'm thinking we're looking more at like chronic disease, and it's how it increases the risk, and then also maybe I think nutrition. So not a problem, Courtney. That's okay. That's what we're here for right now, right?
Yeah.
So you can ask questions. So does that, hopefully that answers the question, Courtney.
Yes, sorry. Yes, it did. Thank you.
All right. Anything else in fundamentals before we move on to farm?
No, I think I'm good on fundamentals.
You don't sound very sure, Natalie.
I'm just going over and making sure I have the stuff that I want.
Keep in mind, guys, I'm always available. So if you run into anything and you're like, oh, I didn't ask this, send me a message.
It's safe to say that you're going to want to know AdPi, right?
Do birds fly?
Okay, thank you.
You're welcome. Actually, I think that one we'll get more into in exam 1, which is the one after this quiz. So you're a little safe for now, but definitely know your nursing process.
The next link I just shared was I created a new whiteboard for farm for any of you guys that want to click into it.
Oh my gosh, you guys are going to be some awesome nurses here. I'm telling you, all of you, every single last one of you. If I do say so myself, you had a great teacher. Oh, just kidding. We just got started. Anyway, all right. So let's start with pharmacy, chapter 2. As you can see, there's gonna be 15 questions and 10 math questions. Okay. Yep. So nice thing is with this, hang on guys, I need more light. It's just a little dark in here and I can't read. All right, so nice thing is with this is, so first thing, when it says nursing implications about a medication or about anything, we're talking about nursing considerations. So basically issues that you would have. Yeah, I tried to link it to a Shelby and it wouldn't let me either. So I'm not sure what's going on with that. Natalie, just FYI. So when we're talking about routes of administrations, like issues you could come up with. So oral. Make sure you're aware that, so here we are on page, oh my gosh. Nursing implications regarding routes of medication. Page, starts on page 22. Natalie, are you your screen? Yep, there she is.
Okay, let me see. See if they can, if you guys can click on the screen with your mouse, they might be able to share it that way.
Oh, because you're sharing your screen, they won't be able to work on the link. So,
Oh,
yeah.
never mind. I'll stop screen sharing.
Okay. Nice try, though. You'll figure it out. Play with it a little bit. Oh, that was weird. Okay, so implications regarding routes. So it is on page 22 and 23. And you're looking at table 2-3. And as I was saying, so when we're talking about nursing implications, we're actually talking about nursing considerations. So I would definitely look at IV and oral the most closely because they're going to be the most common ones that you use when you're looking at those routes. So then examples of the phases of pharmacokinetics. So remember absorption, movement of the drug from its site of administration into the bloodstream. So basically absorption, you take the medication and it goes from where you took it, your GI tract, if you're doing oral, into your blood. Then distribution, when it gets out to everywhere else. So transport via the bloodstream to the site where it's supposed to work. And metabolism is biotransformation. So the chemical is altered into the active and inactive metabolites. And then excretion where it is eliminated. Okay. And then we got the routes of medication administration. Again, same table 2-3, page 23. Difference between enteral and parenteral. Who can tell me what the difference is?
The difference between enteral and
Parenteral.
Isn't parenteral the, well, the enteral is the IV site.
Oh.
No?
Flip-flop.
Flip-flop. Okay, parental is your IV in your arm then.
Yep. Well, it's among other things, actually.
Oh.
But you're on the right track, Natalie. So enteral is anything that enters through mucosa, like the stomach or the small or large intestine. So oral, basically. And then parenteral is any route of administration other than the GI tract. Usually meaning injection. So keep in mind, like sublingual, remember your mouth is part of the GI tract. So parenteral is usually injectable, whether it's IV, IM, sub-Q, even intra-arterial, intrathecal, those are all parenteral. And then enteral are anything that's like oral or through the mucosa of the GI tract.
Would you be possibly asking like an example of parenteral, like nutrition, like TPN, for example?
TPN, no, we won't get into that yet.
Okay.
Although, if you don't know that TPN's parenteral, you need to no, Veronica, we don't need to know meds just yet, guys, because we haven't done that yet. So it's basically knowing the process.
I mean, if you guys want to start studying the meds now, I highly suggest it.
And Shelby would know.
Yeah, back to the biotransformation, the metabolism, the proactive versus, or the active drug versus the inactive portion of it.
Mm-hmm.
Are we going to need to know examples of the inactive and pro drug? Get out.
Examples, not specifically, but actually a little bit further down, actually right after that, routes of administration, you guys will see there's a lot of know the definition. So nicely, in the very beginning of the chapter, you've got your key terms. So page 17, the prodrug is an inactive drug dosage form that is converted to an active metabolite by various biochemical reactions once it is inside the body. So knowing that definition, and it even tells you what page you can like get additional information on. Steady state is pretty easy. It's basically when you have equal amounts drug in your blood and equal amounts are eliminated. So drug absorbed in elimination. First pass effect. Initial metabolism in the liver of a drug absorbed from the GI tract before it reaches systemic circulation. So you take the medication, it's absorbed to the GI tract, and then it goes through the GI tract, and then it goes through the liver to get metabolized before it actually gets into the bloodstream. So that's first pass effect, and that can actually decrease the amount of medications that you're getting, which is why there's a difference between oral and IV dosing. Adverse drug events. I think you guys can probably figure that one out. It's an undesirable occurrence related to administering or failing to administer prescribed medication. Additive effects, incompatibility, and synergistic effects. So additive effects is just that, add and add. So you have one medication and you add another medication and the sum of the parts is greater than each individual part. Okay. Incompatibility, they don't mix. No mixing. So there's a reaction and a chemical deterioration. And then synergistic, again, drug interactions in which the effect or combo of two or more drugs with similar actions is greater than the sum of the individual effects of the same drugs alone. So synergistic effects is a lot like 1 + 1 is greater than is actually greater than 2. Okay, so when they kind of both work together, but it's not necessarily. So you have two drugs of the same type, and the effect of the combination is more than the sum of the individual effects. So make sure you know the difference between additive and synergistic. Additive, we're like 1 + 1 = 2. Okay, 2 is greater than 1 + 1. So drug interactions, additive drug interactions, the effect of the combination is equal to the sum of the individual effects of the same drugs given alone. So again, combination with similar actions equivalent to the sum of the individual effects of the same drugs given alone. This one can be really tricky, I know, guys. So it says to refer to page 32. So basically, like when you have an additive effect, you can use smaller doses of each drug to create a greater effect. So that's additive. With synergistic, two drugs are given, interacted in a way that the combination of those effects is greater than the actual sum of the effects for each drug given alone. So it is kind of confusing, and it's hard for me to be able to really describe it to you guys. Synergistic is kind of when they work together, and additive is when one on top of the other makes it a great thing. PO versus IV and time frame of absorption. So I just mentioned a little bit ago, remember PO, because of first pass effect, you have to have higher doses than you do with IV because of that first pass effect. So you're going to want to pay attention to the absorption, and I think that specific is looking at the safety and quality improvement, preventing medication errors, that QSIN box on page 22, and it says doses IV equal PO question mark. Oops, I need to update the study guide. Know the difference between pharmacokinetics. Oh, look at you. Pharmacokinetics and pharmacodynamics. So pharmacokinetics is the study of what happens to a drug from the time it's put in the body until the parent drug and all metabolites are gone. So basically, until it's all out of your system. You're talking absorption, distribution, metabolism, and excretion. And then pharmacodynamics is the biochemical and physiologic interactions of the drug at the site of activity. So pharmacodynamics has to do with how the drug affects the body at its site, whereas pharmacokinetics is the whole process from the taking a medication going all the way to excretion. And oh yeah, know that 9 rights. Remember, there's 10 rights. The additional right is education. Patient has the right to education. So that is that on pharm. Then, of course, you've got your math. So I recommend actually, using your practice pages in the math book. Keep doing the rapid practice problems and all that stuff, the questions at the end. If you want, you can even change up the numbers and try it, change up the numbers and do it once and then do it again to see if you get the same. So that's what I recommend. It's really, you can probably actually go online and find some very rudimentary worksheets to do these kinds of things. So
for the elimination or excretion portion, are we going to need to know like the primary organs that are involved in it?
No, you just need to know like that's part of the process.
Okay.
Jeanette, yes, the quiz, you do have a time limit. I want to say it's 40 minutes.
For the pharmacokinetics, there's a table or like a little graph about the peak level and trough level. Are we going to need to know something about that?
For this test, no. But in fundamentals, there will come a question down the line about that.
Okay.
So Mercedes, there are 25 questions. So 10 will be math questions, and then 15 questions will be actual multiple choice questions. So the math questions, guys, you're just going to write in your answer. It's a fill in the blank. And a lot of times if the answer hasn't been input correctly per the computer, because I literally do it myself, it will come up as being wrong, which is why I can't give you guys a thumbs up or thumbs down or any of that kind of stuff right away, because I have to go back through them and then adjust for anything. For instance, if you don't, I try to put in everything I can think of that a way you guys might put something. Yes, Jessica, both tests are actually 25 questions, but it doesn't always work out that way. So I believe it's, what is it, 20? No. Yeah. So I want to say it's about 40 minutes for pharmacology quiz, and then 30 minutes for the fundamentals quiz.
Did we talk about first pass effect for the quiz?
Yes. First pass effect is when the oral medication is metabolized in the liver, which then takes out part of the active medication, thereby releasing less active medication into the bloodstream.
Okay.
So that's why IV meds differ with their dosing, because of first pass effect, because you're not having that because it doesn't go through the liver. It's directly into the bloodstream.
And then that would kind of correlate with the steady state with.
That
Portion.
can make a difference.
Okay.
Any other questions, guys? Hang on. Let me look. I see it. So the routes. So when you're looking at the routes, you want to look at page 22, table 2-3. And that'll give you the routes and look specifically at the nursing considerations.
I have that table. If you go into the study guides for the farm that I just loaded, I have that entire table in there.
All right, you guys. I know what you guys are doing this weekend. No, just kidding. So again, any other questions, guys? That's a bad joke, Courtney. No slow deaths around here. You guys are so welcome. I actually really enjoyed this. I'll be honest, this online thing I'm enjoying a lot more. It's kind of weird because I don't get to hear you guys as much, so I might have to change that up a bit because I really need to hear other people. But this is really cool. I think this, for me as a professor, this kind of review session works a lot better. So.
People may hate me for saying this, but I think for a little bit more interaction from us, maybe having us teach you a portion.
Yep. Flipping the classroom is what it's called, Natalie. And that's definitely something I'm working towards. So just so you guys know, this is only my 3rd term at Carrington, so I'm still working things out. But it's definitely something you may see coming, and you're gonna hate me for it. But my throat gets really sore. And everybody, yes, please, by all means, Shelby is definitely a great resource for the math and for help. So by all means, utilize her. All right, you guys, so if you don't have any more questions, I'm going to head out because I do have a meeting, a check-in meeting that I need to go to. But by all means, please, 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 I mean, even over the weekend, send me a message, send me an email. You can actually go back to this chat and send me a message through here on Teams if you want, or send me an email, whichever you want to do, guys, okay? Oh, you guys are very welcome. It's really been my pleasure. I really enjoyed this today. So you guys have a great weekend too. And I will see you guys on Monday. And thank you, Shelby and Natalie, for being so awesome, and Courtney, you guys really putting stuff together. Adriana, really awesome. So. All right, guys, if you guys want to stay on here, you can stay on here and chat with each other. You can do whatever, and I will see you later. Bye, guys.